Let's look again into things that you have heard about, and that is on the HPV and cervical cancer. We know cervical cancer and HPV is so closely related. You can see the HPV DNA or the neoplastic cells in the cervical cancer. And you can see in the these are what we call in situ hybridization. You can locate exactly where the DNA, HPV DNA is on the tissue, and it is within the neoplastic cells. It's not just a question of being there, it is actually integrated into the host genome as becoming part of it. Today, we are here because we are sure that high-risk HPV subtypes is causally related to cervical neoplasia and invasive cancer. Without HPV infection, there will be no squamous cell carcinoma, for example. Look at epidemiological data, looking at what we call the risk or the odds ratios. Having detectable HPV 16 and 18, for example, increase the risk of having a cervical cancer by 280 times. Just to give you a perspective of what this means in terms of the magnitude of the risk of HPV 16 and 18 in cervical cancer, is look at what well accepted for a long time in cigarette smoking and lung cancers. When we look at association between cigarette smoking and lung cancers, the odds ratios is in the order of 20. So the magnitude of risk of cervical neoplasia in HPV 16 and 18 infection is at least 10 times higher compared to the cigarette smoking and lung cancer. But if you look at on the left-hand side here, a list of different HPV subtypes here, you see the difference in terms of the risk ratio is actually quite low. So that is to look at all the different subtypes of the so-called high-risk HPV, the types of HPV associated with cancer development. You can see here this chart look at the risk of developing lesions, CIN3 or more severe, in the follow-up of women with positive HPV subtypes, and the red line shows you the HPV 16. Cumulative risk over the 10 years is approximately 17% of them will develop CIN3 or more severe lesions. Very closely followed by HPV type 18. Of the other subtypes, there are a dozen of the other subtypes of high-risk HPV groups. You can see the risk of the 10-year cumulative risk of CIN3 plus lesion is approximately 3%. Compared to women who were negative for high-risk HPV, the risk of CIN3 plus was below 1%. So although all the 14 subtypes of HPV high-risk are so-called high-risk and oncogenic, but 16 and 18 stand out as a very distinct type of subtype. If you look at you'll be able to clear HPV infection from the genital tract for all the different types of HPV, and will be type 16 and 18. Otherwise, you and I would not be sitting here, we'll be all cutting away the services in the hospital. So luckily, a lot of women, despite having acquired the infection, are able to clear it. But there is a difference between different subtypes of HPV in terms of the duration of infection. That means how long does the virus stay on the cervix persistently before the woman clear the virus. So for 16 and 18, the different studies here are consistent in 16 and 18 have a quite long duration of infection before clearance compared to say type 6. Most of them clear within 6 months, whereas 16 and 18 have a median duration of infection of more than 12 months. The persistence of the infection plays the important part in development of transformation of the normal cervix cervical cells to neoplastic cells. And so if you look at the single type of HPV detection in cervical cancer, 16 alone accounted for 56%, is found in 56% as a single HPV infection. 18 is found in just under 10% as a single type of HPV infection. If you also include those cases that there are more than one type of HPV infection, but they involve 16 or 18, around 6%. That means that in cervical cancer, 16 and 18, the two of them accounted for more than 70% of cervical cancer. The same kind of dominant 16 and 18 is squamous cell type as well as adenocarcinoma. Although there is a slight difference in terms of the preponderance of 18 in the adenocarcinoma of 30%. But if you look at they are the most important. If you think that the worldwide prevalence of HPV may not be applied to this part of the world, while you may be misled. Because if you look at Asia, this is a HPV subtype distribution. Looking at all squamous cell carcinoma, adenocarcinoma, high-grade CIN 2 and 3, and low-grade lesions, you can see very distinctly is the type 16 and 18, the two of them that are most common. So as far as the cervical cancer is concerned, HPV is no different in Asia or in the Europe or North America. So in a way of summarizing this background information, I'd like to point out again that it is very important in 18 and subtypes in the sense that they have a higher transmission between partners and also have a longer persistence in the cervix, and they are, compared to other high-risk subgroup, particularly high oncogenicity, meaning that they have a very high virulence in terms of the virus inducing transformation. It has a short progression time from normal cervix to CIN2 or more severe lesion. We keep talking about persistence of the HPV infection being important, but it has been shown that a lot of women develop CIN2 plus lesion very shortly after acquiring HPV 16 infection. It's not surprising that a lot of them were positive for CIN2 plus lesion within 6 months, for example. So this short progression is important. And it is also very consistent of the prevalence of 16 and 18 in cervical cancer throughout the world. So much that we know about HPV, different subtypes, particularly 16 and 18, as a different subgroup of the virus. So with this information, how would our management be affected, being people dealing with women with HPV infection and with cancer prevention? So for the next few minutes, we look at how HPV DNA test can help us in management of women with abnormal cytology, since cytology screening remains the most proven, time-proven, and also most prevalent method of cervical screening worldwide, including here in Malaysia. There are plenty of studies showing how frequently the pap smears are abnormal. I just put up one of the data from UK, from the Bristol between 1988 and 1993 of 225,000 women, and look at different grades of dyskaryosis, the abnormal pap smears they have. I must apologize for the difference in the terminology used in the British Isles. They still use the dyskaryosis in the descriptive term, severe dyskaryosis with the HSIL, and the mild to moderate would be the LSIL, and borderline dyskaryosis would be equivalent to ASCAS that you are familiar with. So for this group of women, you can see that the rate for abnormal pap smears in the category of ASCAS or borderline malignancy dyskaryosis is something like 32 per 1,000 pap smear. That is just over 3%. And this is no different from the rest of the world. That's why I just use this to show you that there are a lot of this. And in terms of management that we are interested in, management of severe and maybe even moderately dyskaryotic pap smear is quite clear-cut. all of you know that you evaluate the cervix with colposcopy and biopsy when necessary. But the controversy and the challenge that we have is this very large number of women with mild abnormalities. But they are not to be dismissed because there is a certain proportion of them, significant number of them, would have high-grade lesion on the cervix despite mild cytological abnormalities. And that is where the challenge is. Which of these large group of women with mild cytological abnormalities actually harbors a CIN2 plus lesion that we should find out and to work with? Since we know HPV high-risk subtypes are so central to the development of CIN as well as cancer, so obviously they will play a very important part for us. And looking at HPV DNA tests, and there are numerous tests available and used by different doctors, but if we look at those tests that are really well validated for clinicians to work on patients, make sure of the safety of our patients, the tests that we use must be reliable, must be validated, and one of the surrogate measure of a validated test would be FDA-approved technology. And for HPV DNA up to date, if you look at the list of the FDA approval, there are this list of tests available. The most sort of well-established would be hybrid capture 2, but more recently I should say, there was Cervista high risk provided by Hologic. They look at both of these hybrid capture 2 and Cervista high risk were similar in the way that they have pooled high risk HPV subtypes. They tell you it is positive, but it can be positive any one of the 14 subtypes of high-risk HPV. That's why it's called pooled subtypes. But for Cervista, they have a second test called Cervista 16-18, which would be able to test for 16 or 18 subtypes. But this is approved by FDA to be tested only on the group who had previously been proven to be HR positive. That means you'll be doing 2 separate tests on the sample. The only one that has been approved as a single test for both HPV 16 and 18, as well as 12 other high-risk subtypes together in one single test, will be the one called Cobas 4800 series, provided by Roche. So as we have seen earlier, that not all high-risk HPV subtypes are similar, and particularly 16 and 18 will be the most important subtypes in terms of the malignant transformation potential. Obviously, we would be interested to know how this kind of test, singled out the 16 and 18, would be of practice to us. Now, earlier I alluded to the large group of women with ASCAs that we have to manage and we face the challenge. This is the data is a meta-analysis of 4 series of publications looking at ASCAs. The population incidence or prevalence is approximately 3.8%. That means it's the same as the Bristol data I showed you earlier. 3.8% of the cytology you screen in the population would turn out to be ASCAs. And since the available of the hybrid capture 2 in the last 2 decades or so, they have been widely used in algorithm of marriage management. So this group of women will be tested for the presence of high-risk HPV DNA. And approximately within this series, 43% of these ASCAs will be positive with the high-risk HPV. And the other 57% will be tested negative. Those that are high-risk HPV negative, they are at extremely low risk of having a CIN2 or more severe lesion. So this group of women can be sort of managed in a slightly more conservative way, similar to the rest of the screening population. But this group with high-risk HPV positive would have a significant proportion of them having CIN2 or more severe lesions. So the algorithm would be for this group to be immediately referred to colposcopy clinics for management. That means you'll be referring 40% of this large group of patients to the colposcopy clinics. And of this, if you do the evaluation colposcopically and biopsy the abnormal lesions, approximately 1 in 10 of them would indeed have CIN2 or more severe lesions. This 1 in 10 is the absolute risk of having a CIN2 or more severe lesions. And we'll keep this number in mind because it will be important. Now, looking at the new test now just been approved by FDA using this COBAS system, the test actually within one sample can go through the nucleic acid isolation PCR technology and generate the data report in approximately 5 hours. And what it would provide will be in one channel looking for the 12 subtypes of high-risk HPV, and separately will be one for the 16 and one for the 18. The other one, what we call the beta globin chain protein, is an internal control to make sure that the system has worked so that you could actually believe the results. The system has been validated and proved to be reliable. So with this technology available, the data I'm going to talk on comes from what we call a TINA trial, which is a prospective double-blind trial with an aim to look at the clinical significance of using 16-18 genotyping in the United States screening population. And in this prospective trial, they recruited more than 47,000 women who presented for the routine screening, and the entire study would be over the 3 years of follow-up, and the full data is expected to be available in 2013. Just a little bit of details of the study designs. So with these women who are presenting for the screening and above the age of 21 years old, there were 47,208 women, and they undergo 2 tests. They have a cytology, liquid-based cytology, as well as they have a HPV analysis using the COBAS system. So there are 3 different kind of category of these outcomes. There will be a group of women, both negative for both cytology and HPV. They were called cytology and HPV negative. There will be a group of women that is cytology negative, but HPV DNA positive. In all studies, you will see that this is approximately 10%. 10% of women would be in this group of women with no cytological abnormalities, but HPV high-risk positive. And this would be a group of women, cytology were abnormal, and they could have a series of different kinds of HPV DNA positive. So these are the 3 categories of women. In terms of this particular study, for those women who were negative for both cytology and HPV DNA, then the younger women, because the recruitment includes women above 21 years old, but you know the risk of these young women are really quite low, and regression rate is quite high. So for this study, any women in this group below the age of 25 years old, they exited the study. They will no longer carry on with the long-term study. But those who were more than 25 years old, a group of them were randomly selected to go for colposcopy and biopsy if necessary. And these were about 1,041 women. So they work as a negative control for the study analysis. And for the other group, cytology negative but HPV high risk positive, if they were more than 25 years old, then they come for the long-term follow-up arm, where they will be evaluated with colposcopy and biopsy. And the other group with cytological abnormality, regardless of the HPV result, all will be evaluated by colposcopy. At this point, any women detected to have a CIN3 or more than CIN2 lesion would go for clinical management according to the management of high-grade lesions, so they would not be followed up for the next 3 years. Only this group of women with lesions less than CIN2, then they go on for the 3 years long-term studies. Now, to summarize these subpopulations stratified by the cytology, we started with a total population of more than 21 years old of more than 47,000. This group of women with no lesions, they were excluded. And those that are subpopulations, then they will have a group with ASCAS and a group with no cytology abnormalities. Now, first of all, just quickly look at the ASCAS, the group that we are interested. There were 1,923 women over 21 years old. They are particularly interesting for us because the objective is to evaluate how the presence of 16 and 18 would help us to manage this group of women. So of the 47,000, about 1,900 are in this group, and for this particular trial, the prevalence of ASCAS is 4.1%, which is in agreement with the earlier publication of 3.8 in the meta-analysis. Of this, 85% came for the colposcopic evaluation, and 82%, that is 1,578 patients, have biopsy and HPV results sort of valid for analysis. The demographics of this group of populations were, the mean age was 37 years old, and a third of them were in the young women below 30 years old, and just over a quarter were in the mid-30s, and 41% over 40 years old. 23% were postmenopausal, and 96% of them have never received any HPV vaccination. Now, the prevalence of high-risk HPV is detected in 32.6%, and this is slightly lower than the 43% I quoted earlier in the meta-analysis. Nonetheless, 32% of them were positively high risk. Of this, you can see that about a quarter of them is HPV 16, and another 10% were HPV 18. So between 16 and 18, it accounted for 1/3 of this group of high-risk sensitivity. To be fair, as a comparison to the hybrid capture tool, which is a pool data on high-risk HPV, we can do the same comparison, although the data does provide 16 and 18. Let's forget about 16 and 18, just put all the 14 groups together using the two systems. That means they're using the pool data, looking at first the sensitivity for detecting CIN2 or more severe lesions. You can see that for COBA system, the sensitivity is 90%, which is comparable to 87% by the hybrid capture tool. If you look at the specificity for this CIN2 or more severe lesions, it's both in the term of 70% for both of them. Positive predictive value for a positive test is 14% for the COBA system and 13.7% for the hybrid capture tool. Negative predictive value are both equally good at more than 99%. That means that if we just look at the pool data, the two systems look exactly the same in terms of performance. But if we look at in terms of management, what can we do with the management? On the left here is based on meta-analysis of ASCAS. All the ASCAS patients go for high-risk HPV DNA test. 43% will be positive with high risk, and 1 in 10 of them would have CIN2 plus lesions. If we look at the Athena trial results, 32% will be positive for high-risk HPV, and 1 in 7 of them have the CIN2 lesions. That means the two systems on pool data basis of analysis, they are equally good. So what is the clinical benefit of knowing 16 and 18? If you look at CIN2 plus lesion, you can see that 16 or 18 were found in 53.8%. Majority were from HPV 16. So this, knowing if you know that 16 and 18 is present, it would really show you the subpopulation of ASCAS with extremely high risk of having CIN2 plus lesion. Looking at it another way, this is the pool data showing that high risk HPV positive is a predictor compared to the high risk negative women. But if you look at HPV 16, 18, look at the 12 subtypes of HPV high risk, and compare with 16 and 18 alone, you can see that 16 and 18 highlight, the group of women at almost 3 times higher risk of having a CIN2 plus lesion. If you don't like CIN2 plus as an endpoint and look at CIN3 plus alone, you can see it's the same. HPV 16 and 18 detection highlighted 3.6 times higher risk of having CIN3 plus lesion among these ASCAS women. Therefore, we can look at the impact of having the knowledge of 16 and 18 genotyping based on this trial, it really identified women who are at highest risk for having disease that needed more urgent management. So we can summarize this in this way, that HPV 16 and 18 genotyping identify these extremely high-risk women for CIN2 class lesion, and that the physicians can focus on managing this group in a more intensive way, both in terms of managing them as well as post-treatment follow-up. So it is very useful. But in view of time, I would like to very quickly run through some of the data, looking at a group of women that if you should adopt HPV and cytology screening system. What is the value of 16 and 18? We have heard a lot, and this slide summarizes our current knowledge of HPV infection, which is very, very prevalent in the young women in the early 20s, and then the prevalence sort of reduced to a more steady background risk of approximately 10% throughout the rest of the woman's lifespan. Pre-cancer, the CIN lesions would peak in the mid-30s, whereas the invasive cancer would come along near late 40s. And if we are going to do HPV DNA test, we have to select, the age group of women that is most relevant to have the HPV information, where the pap smear can be used throughout. To summarize many of the data that we have in hand, using the different type of systems to detect CIN2 class or more severe lesions, HPV DNA tests based on meta-analysis of many studies show that consistently the sensitivity is just over 90%, whereas the cytology has a sensitivity for detecting CIN2 class of more, just over 50%. So clearly, in terms of sensitivity, HPV DNA testing is in favor as the test for the screening. Now, there are many trials, and for us, based on the evidence, we are looking at the randomized control trial for the primary screening of cervical diseases and using the HPV DNA test. To date, there are 5 large studies involving many thousands of women in the last 5 years looking at this particular issue. Most of the studies have 2 arms using the cytology screening, both liquid-based cytology as one arm, and hybrid capture 2 HPV DNA testing on the other arm. In these 2 studies, these are FIN studies, cytology was used as a triage. It means that HPV positive, but cytology is used to decide the management. The SENCA study from India, which is the largest study, and they also include 2 other arms, the VIA as well as the no screening as a control. Now, without going through the details of individual studies, let me just summarize for them to you. First, HPV testing has greater sensitivity than cytology testing for detecting CIN2 class lesion. And this HPV DNA test can be applied as the sole primary screening test in the test. Primary HPV DNA screening with cytology trials will find more CIN lesions compared to just using the conventional screening. The caveat is there will be a lot of mild lesions detected in this way. So we all know that there is going to be about 10% of these women who are going to have cytologically negative, but yet HPV high-risk positive. And what are we going to do with this 10% of women? Currently, the suggested algorithm of management is that one should offer the women another repeat test of both cytology and the HPV DNA test within 12 months, and based on this, decide whether they should go for the colposcopy or whether they can be accepting the examination, the screening, the intensive follow-up. Now, this kind of algorithm has not been very well accepted because a lot of people are not sure what the presence of this high-risk HPV is going to mean. So looking at Athena data that is going to help us, as I alluded earlier, we have this group of women who were negative for cytology as well as the HPV who come for colposcopy as a control group. And there's this central group, cytology negative, HPV positive, and more than 25 years old and come for this colposcopy. And we look at subgroup of these two categories and select the women more than 30 years old and present the data in the next 2 minutes. This subgroup of women will be exactly the question we have in mind: normal cytology and HPV positive. The median age of these 32,000 women were 44 years old, and 35% were in the mid-30s, and 65% more than 40 years old. 38% were postmenopausal. Almost all of them have never received the HPV vaccination. 91% had previous pap smear. 78% never had abnormal pap smear. So the question is, how often and what's the prevalence of high-risk HPV DNA among these 32,000 women? Well, the prevalence is 6.7%, just slightly less than 10%. That's because we have a group who are already selected as HPV negative and cytology negative, so 6.7%. Of these, about a fifth of them were 16 and 18 positive. A fifth of these. So we look at the endpoint, the absolute risk of CIN2 or more severe lesion, and you look at this particular group, the 12 high-risk HPV positive group had a prevalence or risk of 4.6% of having CIN2 or more severe lesion, compared to 11.4% if 16 or 18 were positive. That means almost 1 in 9 of these women who were tested positive for HPV 16 or 18 and who had a negative cytology actually had an ongoing CIN2 or more severe lesions. 1 in 9 of them. And if you again use a more severe endpoint of CIN3 lesions, you still see if 16 and 18 DNA were detected, almost 1 in 10 of them would have CIN2 or more severe lesions. Compared to the other high-risk HPV type, the risk was only 2.4%. So, if we use in terms of management strategy, what to do for these women, there is this castle model looking at risk of CIN2 or more severe lesion as an endpoint, and look at the risk. If the risk is very low, between 0% to 2%, we are not too concerned with the risk of this group of women. They can be followed up with regular screening in terms of management. If we have the other women having the risk of between 2 to 10%, they were at a moderate risk of having CIN2 or more severe lesion. This group of women need more intensive follow-up. Perhaps they need to have a screening on a yearly basis rather than 3-yearly basis. If the risk is more than 10%, then obviously none of us as a clinician would like to take the chance of missing this group of women who might have a CIN2 or more severe lesion. They should immediately be referred to colposcopy for further evaluation. So this 10% risk would be what we call the threshold risk, triggering clinical action. So if you accept such a management strategy, then how would the data fit in? If you look at the group of women, negative cytology, negative HPV, high-risk DNA, their risk of having a CIN3 lesion, severe lesion, is no more than 0.3%. So this is really a low risk that we can afford to go on regular screening at 3-yearly interval. But if you look at, if they were positive for any one of the 14 subgroups of high-risk HPV using the pooled DNA test, the risk of CIN3 lesion is 4.1%. That means that if you use the hybrid capture tool or one of these technology, you would say that having a negative cytology but positive high-risk HPV, they are now at a moderate risk of having a CIN3 plus lesion. You can no longer put them at 3-yearly follow-up. You have to do more regular screening. If you look at ASCA, the cytology is slightly abnormal. The risk of CIN3 plus is 8.4%. And this group, in fact, if they were ASCA, would have immediately referred for colposcopy. What about the normal cytology? They have normal cytology, they have 16 or 18%, their risk is 9.8%. So clearly, 16 and 18 identify this group of women to be extremely high risk for CIN3 plus, reaching the trigger point level for you to refer for cytology. So 16 and 18 would highlight to you the group of women that you can no longer using this kind of algorithm in the past, and using the new suggested algorithm would be a fifth of them, 22%, would be 16-18 positive, and despite the cytology being negative, they should be evaluated by colposcopy. In the other larger group, HPV high risk positive, but not 16 and 18. This group, they are at moderate risk. They can perhaps go on to 12 monthly interval. So I finished my presentation of the data. I just want to conclude the ATHENA data to show us that absolute risk of CIN2 or more severe lesion in the screening population of women above 30 years old is about 1.2%, and the high risk HPV DNA positivity is 6.7%, of which 1% will be 16 positive and 0.5% 18 positive. And if in terms of absolute risk of CIN3 lesion, 9.8% of them were in the group of 16 and 18 positive, and they ought to be considered for immediate management. So on a practical level, I would like you to consider that individual HPV 16-18 genotyping reported with 12 full high-risk HPV results would identify women who are at an extremely high risk for immediate cervical cancer assessment. If you use this kind of technology in the triage management of ASCAS, then you would identify the group of women who have a risk of 1 in 4 of CIN2 plus lesion. Even if you use this in a co-testing system, if they are cytology negative but 16-18 positive, they are having a 9.8% chance, 1 in 10 chance of having CIN3 or more severe lesions. So instead of just using pooled data, you might want to use the individual genotyping in terms of managing this group of women. With that, I would like to conclude. Thank you very much.